after the lectern. Debbie is a lived experience mental health advocate and is actively involved in improving NDIS psychosocial pathway. She is also currently undertaking a PhD part-time. Her research seeks to explore choice and control for NDIS participants with a primary psychosocial disability through Sydney University. Debbie lives with a bipolar 1 challenge, diagnosed when she was 27, and now has an NDIS package that has significantly improved her life. She's contributed to developing the Mental Health Consumer Carer MHCC, the Reimagine website to assist people with psychosocial disabilities to navigate the NDIS. Debbie sits on various committees and boards to provide a lived experience perspective about serious and persistent mental illness. Debbie has a Bachelor of Medicine with honours and a graduate diploma in bioethics. Her background includes working both as a registered nurse and emergency doctor. And Debbie loves having a home. Welcome to the stage, Debbie Hamilton. Thank you very much.
Clear enough? Yes, okay. I've got the wrong glasses on and you're all blurred, so. I did think this was kind of like, this is Zoom, but it's an equally well because you've got a tummy meter. Do you see how you can see underneath? Yeah. So, yes, I'm going to just nod when I need a slide changed. I'd like to acknowledge that we're on the lands of the Gadigal people of the Eora Nation, and I pay my respects, and I acknowledge the enduring relationship that First Nations people have with the land, and I respectfully acknowledge elders past, present, and emerging. And you know what? I express my sorrow personally for a lot of racism going on in Australia at the moment. So, to talk to you about iatrogenic harm. That is doctor-inflicted harm perpetrated on people with a mental illness, mental distress. How I had read The Nemesis of Medicine by Ivan Illich as a prerequisite reading before I got into medical school. It spoke of the way medicine since the 1950s had driven a societal obsession with health, and how the word coping is actually fairly new in the English dialect, and how we continue to avoid suffering in our lives. Interestingly, it looked at what medicine, it didn't look at what medicine did, but what it said about us as people. And I was going to then go on to talk to you about the types of prevention, like primordial, primary, secondary, tertiary prevention, and tell you that it really worries me that many of you are mopping up pharmacological disasters doing secondary prevention rather than getting at the coalface and changing the way people with mental distress are treated. How the expediency of drug treatment and the questionable psychosocial model has outweighed a much more timely, sensitive approach that's person-centred, that enables personal choice and control with a fully formed consent. But no, I'm not going to. I've said it all. What I am going to talk to you today about is sex. Now, I know that it's in the news at the moment. Yes, please. And I want to think, you know, how can we innovate a new exercise program? I noticed that I couldn't see anyone else talking about sex on the program, yet sex is extremely important for wellness, our sexuality. And it certainly isn't an area of equal wellness. Sorry. It's a way of having exercise, intimacy, and companionship and fun all at once. Overall, research has found that sex in many forms is equal to light to moderate exercise. It's a way of working collaboratively to reduce health inequity. our sexuality is pathologised by the psychiatric fraternity. According to DSM-5, we're either too slow, and it's got this other line in the DSM-5, there is some evidence that this may be associated with severe depression, or too fast, anything less than a minute. And this seems to only happen to men, but that was news to me. And the next one. Or too much, you're risking your reputation, or not enough. And this is the great clangor from the DSM. It says, the judgment of deficiency is made by the clinician. So it's there in DSM. Or you don't like sex at all. But woe betide you if you find shoes sexy, because you'll have some kind of paraphilia. And personally, I like high heels, so. But seriously, these particular issues can be very distressing for people, and we all need to be open and prepared to talk about it, about people's sexuality with them. To do this, we need to be comfortable with our own sexuality. We need a language and that befits the person that we're working with, and we need to have a bit of knowledge of sexual physiology, and we need to ask the question that isn't asked. Patricia Deegan would invite us to consider those of us who've been diagnosed with major mental illness do not cease to be human beings by virtue of that diagnosis. Like all people, we experience the need for love, companionship, solitude, and intimacy. Like all people, we want to feel loved, valued, and desired by others. The greatest and most healing service that can be offered to people with psychiatric disabilities is to treat them with respect and honouring them as human beings. This means honouring us in our full humanity, including our sexuality and our desire to love and to be loved. So what's important to know about sexuality? The World Health Organization has said it's a central aspect of being a human throughout life and encompasses gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. It's influenced by the interaction of biological, psychological, social, economic, cultural, legal, historical, religious, and spiritual factors. This definition placed little emphasis on heteronormative performances of gender and sexuality through acts of sex, but instead emphasises the numerous intersecting factors which influence an individual's conception of themselves as sexual beings and their behaviour in relation to their sexual thinking and feeling. The WHO definition of sexual health has more of a rights-based focus. There it is, yep. A state of physical, emotional, mental and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction or infirmity. Sexual health requires a positive and respectful approach for sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, free of discrimination, and free of violence. So the manner and form in which sexual understandings and behaviours emerge is imbued with social meaning and is largely, but not exclusively, socially determined, which makes it very important for us when we're talking about mental health. When I studied medicine, I studied sexuality. In fact, I did the year twice because I got sick at the end of one year, so I got to do sex twice. And the first time the whole year failed in the exams, which is really quite funny, but everyone failed. So, but no, eventually I passed. And we did a video role play of talking to someone about their difficulties with sex. And the course was really innovative. We watched lots and lots of erotic movies explicitly about the act of sex and sexuality. It was a great course, and I did it twice. Experience of interviewing someone and the things that I found challenging at the time. Finding the right words to explain things in a way that the person would understand and be similar to their language. And I discovered quite interesting some things, you know. I hadn't really developed, I mean, I could give a physiological, you know, anatomy thing, but I couldn't really, I remember stumbling over my words. I remember reflecting on my own sexuality as a lesbian and what I thought was normal and what other people might think is normal. I think the fluidity about talking about sex and how actually I was uncomfortable, even though I was trying to be really cool and I knew it all. And the importance of listening to what's actually being said, knowing about the actual physiology of sex, the different stages of the act of sex, and the importance of listening. Yes, I said that. I share these thoughts with you so that you might yourself reflect on when you've talked about sex with someone, might have been a partner or hopefully a consumer, and you know, what it was like for you. And your own definitions of what's normal, of what's acceptable, well, is going to open and close doors without you ever knowing, because your body language will tell them everything. Previous speech about severe mental illness with, we aren't the sexy, have these 10 psychology sessions, get well soon people. We aren't all young, inhabiting the preventative headspace. We aren't even blue or butterflied, and we don't really have a day or a ribbon. We run under the radar. Many of us have lost our jobs, our reputations, our family, friends, and homes. We aren't the poster people of mental health. We aren't all pretty. And I was wrong. We're things. And for lots of reasons, we don't talk about it, and we don't see people with mental illnesses necessarily as sexual beings. Historically, the psychiatric profession has a great deal to answer for it when it comes to sex. And given that those who cannot remember the past are condemned to repeat it, it's worth a moment to reflect historically about the psychopathology which has either been the cause or the result of our sexuality. The evils of masturbation and losing your seed, and the cautery of clitorises, the eugenics movement, ridding the world of mental defects, delivering electric shocks to uteruses. And then there's homosexuality. And I wanted to tell you the story of one of my good friends who endured deep sleep therapy in Chelmsford Hospital because she was attracted to women. She was, like, and these pictures are amazing. She kept in a comatose state for weeks and weeks, and she was given massive doses of barbiturates. She lay naked in the bed with just a sheet over her, and she was fed through a tube. She was sometimes administered ECT while she was in the coma. The treatment major proponent was a guy called Dr. Harry Bailey, and he claimed that deep sleep therapy would cure depression, it would cure compulsive behaviour such as drug and alcohol, and it would certainly cure homosexuality. Over a dozen patients died in Chelmsford and more afterwards. Many people suffered brain damage. In fact, my good friend cannot modulate her feelings. So in any one sentence now, she's literally in tears, giggling, happy, sad. She received the largest payout of anyone from Chelmsford. One day, she woke up enough to wonder what's going on. She stopped taking her tablets, she hid them under the bed. And then one night, in the middle of the night, with just a sheet, she took off up to the railway station. And that is so sad, isn't it? And I worry because abortion is now illegal in America. We're banning books about sex that actually tell the truth. People don't have to serve homosexual people in America if they're a couple. How will psychedelics affect our sexuality? Who will be the newest Charlie Teo of the psychiatric world? So, having been a doctor, number 13, having been a doctor, that medical professionals intend to help people, not to hurt them. However, we really shouldn't look away from the facts of history. The long track record regarding the sexuality of people diagnosed with mental illnesses isn't great. The temptation of distress, like dismissing the past and saying, oh, it could never happen again, is wrong, because it could happen again. And just because they've got, we're of the scientific age, randomised controlled trial, evidence-based, meta-analysis. The problem is mental health professionals need to learn from the past and dare to question the assumptions which guide their work and the very questions they ask about their work. It behoves all of us to think about not what psychiatry does, but what it says about us that we let it happen. Next slide, thanks. So, in the 36 years that I've had my bipolar illness, no one has ever asked me about my sexuality. No one. And how it might be affected by my mental illness, by the drugs that I take to stay out of hospital. Sure, I've told them that I'm a lesbian, and I had one psychiatrist say to me, you practice serial monogamy. I can deal with that. But it's interesting, really, because very few of us are asked about our sexuality and the impact of our mental illness and medications. They certainly have used my sexuality to schedule me in the past when I've been too fast, too often. One person said, a consumer, for want of a better word, my biggest problem with sex is medication. These pharmacological companies should warn you, and they just don't. They don't warn us of the sexual side effects. The pharmacy companies should put the learnings right on the bottle. The reality is that much emphasis is placed on involving patients and their carers in prescribing decisions, but the reality is something else, and it can be done. Many people in this room will have studied sexuality at their undergraduate courses. It's certainly in the curriculum, but how many have used that knowledge since? The reality is that much emphasis is placed, not everyone with a severe mental illness nearly everyone with a severe mental illness has had their sexuality affected by medications. We would have liked to have known, been asked and given informed consent. Personally, I don't know what's been better for my sex life, risperidone with leaking breasts from milk, or maybe it's the 30 kilos I put on with Seroquel, or maybe my sexuality is affected by my lithium tremor. Most of us have never been informed about the possible sexual dysfunction related to medications or the use of concomitant and the experience of concomitant sort of blunting, apathy, indifference. We tend to blame ourselves for our sexual dysfunction and subsequently feel ashamed and at times struggle. Consumer said, I have the problem that my medication gives me, which is premature ejaculation. They keep telling me, you have to take this medicine. There's no other medicine you can take. You have to accept this side effect. When most of us with a mental illness or distress encounter drug effects that impair the quality of life, we want to work collaboratively with health professionals. We want to try different dosages, try different drugs. And back to my point, not give drugs, but use them minimally and teach people other techniques. Suggesting a trial period with an end time when people can review what's going on. Putting a reasonable time frame on that. When evaluating a person's long-term medication use, their health and well-being, take time to inquire about drug side effects. Notice I didn't say, well, I did. I said drug side effects when I meant to say drug effects. That was a good one, wasn't it? See, the doctor in me. Some people have become so accustomed to sexual dysfunction and loss of sexual desire that they might not even mention it. In taking the time to explore these issues with people, you demonstrate care for the whole person and the overall quality of their life. We all know that experiences of childhood abuse can affect our sexuality. But we can also be affected by the very experiences that happen in mental health units, where being held down and IV'd and all those experiences, people find akin to rape. And my multiple experiences of that happening are some of the most absolute traumatic experiences in my whole life. And they've certainly are some of the things, along with my mental illness, my medication that I'm on, affecting my sexuality, but not completely. So, stigma and discrimination play a big role in the barriers to the expression of our sexuality. Our experience of sexuality is experienced on a set of cultural norms about beauty and prohibitions of others. If we don't fit in the norm, then we're in trouble. Sexuality is one area we can recognise a model of exclusion at play. The majority of sentiments about what's normal and strict notions of sexuality have thwarted us. What we wear, whether we've shaved. Let also not forget the huge impact of poverty, of marginalisation, unemployment, poor housing and second-class citizenship. All of those things affect how others view our sexuality. What are our chances of relationship? And telling people. And it's hard. It can be hard. It's difficult to initiate a new job and tell them that I've got a mental illness, let alone having a romantic relationship. And the discrimination's internalised too. Now, at the moment, the buzzword is recovery model. Next one, thanks, sorry. And the next one. There we go. The recovery model. This looks like exercise that we just did. I'm cool, aren't I? Okay, the mental health system is heavily influenced by this model, and that we will recover even if we've got symptoms, and that's good. It emphasises the person in relation to their illness, their self, others, their social role, and where they fit in society. Recovery approaches emphasise principles of choice and self-determination, skill building, self-help. The recovery model also allows us to take risks. Although paternalism in the mental health world is right, it should allow us to make mistakes and fail, have relationships go bad, like all of us have. The recovery model also embodies the importance of valued social roles, such as worker, musician, artist, chaplain, whatever work you do, rather than persistently ill person. And we should work to maintain the valued sexual roles like partner, husband, wife, lover, boyfriend, to be preserved as much as possible, because reclaiming these roles is an important aspect of finding recovery. We live in a time when we think we talk more openly about sexuality and recognise its centrality in our lives, but we don't recognise this as an integral part of wellness, of wholeness, of equality.
I think this is real, folks.